Welcome to Beyond Bones and Muscles, a Legent Health podcast. Created by the team at Legent Health, a healthcare system devoted to helping you live life to the fullest. Your health, our priority. Each episode, Chief Operating Officer Daniel Brazel keeps your finger on the Legent pulse, going beyond the bones and muscles of Legent Health. We will discuss orthopedic and spine industry education and analysis, along with news from around the Legent healthcare system.
Hello, everyone. My name is Daniel Brazel. I'm the Chief Operating Officer here at Legent Health. I'm excited to bring you our Beyond Bones and Muscle podcast, and I'm really excited today specifically to introduce our Chief Medical Officer, Dr. Adam Bruggeman, who's going to be talking to us about some important topics related to advocacy. Dr. Bruggeman, as our Chief Medical Officer, who resides primarily out of San Antonio, as a surgeon, he's heavily involved in advocacy across the United States, spends a lot of time in D.C., and is really a subject matter expert relative to the two topics that we're going to dig into this afternoon. So, Dr. Bruggeman, welcome to the podcast, and how are you today?
I'm doing well. Thanks for having me on.
All right, very good. So I know you're very passionate about this. You and I have spent a lot of time together over the past year or so. And in my past life, I spent a lot of time in California dealing with advocacy issues related to surgery centers at the state capitol. And I know your breadth and scope is much bigger than that, dealing on the national scale in D.C. And specifically what I would like to talk about in this podcast is two topics. And as we go through each topic, we can obviously pivot and kind of dig in deep on some of the items. But the first one is related to physician-owned hospitals and really what they are. And then prior authorization, which is a really hot topic in the medical industry, where a lot of surgeons and physicians are concerned with that topic specifically. So as we think about physician-owned hospitals and really drill down into that, I want to take a step back with you, Dr. Bruggeman, and really understand, what does that mean when we say physician-owned hospitals? It sounds sort of intuitive, but there's some nuance to it as well. And why is that relevant to us here at Legent?
Yeah, no, those are great questions. So let's start with the first part. What is a physician-owned hospital? What that is a facility that provides inpatient care to patients, typically surgical care, but can be internal medicine care, can be, COVID care, could be other things. But typically what we see is a tertiary hospital that performs surgery and sometimes also has medicine style units on it. And those facilities, if they have a physician with a practicing license who owns it, are considered physician owned. And that distinction became important after the Obamacare or Affordable Care Act was passed. And during that bill, unfortunately, there was a section in it to get all of the various stakeholders on board. There was a section in it that said that physicians could no longer own hospitals if they hadn't been completed by a specific date in 2010. So up until 2010, physician-owned hospitals were legal. There was an ability to do so, and there are several throughout the state of Texas. After 2010, only those facilities that were in existence prior to the bill going into effect were allowed to continue, but they were not allowed to expand. So the total number of operating rooms and inpatient beds combined could never be exceeded. So if you had 10 operating rooms and 30 beds, you could never exceed some combination that added to 40. You couldn't have 41 or 42, even if the demand was required in your area without a waiver. And those waivers largely were given or have been given to people who treat a significant Medicaid population.
Okay. That makes sense. So maybe expound on that a little bit more in regards to what you're seeing at the Capitol, because I know there's a push to potentially get some amendments to the Affordable Care Act related to physician-owned hospitals, as far as the need and expansion of it. What are you hearing? What are you seeing as far as what's going on at the legislative level to potentially make changes to that provision? Because it has, there was a moment in time, you were either grandfathered in or you're not. And is there any opportunity or any line of sight to seeing that being revised?
Yeah, it's a great question. Every congressional session and Congress meets has sessions for 2 years at a time. So it follows the terms of members of Congress, particularly the House of Representatives, as they turn over every 2 years. They have to either pass their bills before the end of 2 years or reintroduce the bills at the next session. So every 2 years, we've reintroduced a bill in Congress, we being orthopedic surgeons in particular, as well as some of the other specialty organizations. That bill has been designed to repeal the section of the Affordable Care Act that deals with physician ownership. Um, Initially, obviously, there was very little momentum. There was a concern about self referral, that physicians would either overutilize or somehow overadmit to hospitals that they owned in, and therefore perhaps they weren't the best people to own hospitals. However, as we all know, surgeons are allowed to own ambulatory surgery centers, which would theoretically have the same problem. And they're allowed to own other components of their practice for the convenience of patients. And so over time, that argument has waned down. There's been also an argument about something called cherry picking, which is the concept that surgeons only take their high paying patients or their healthiest patients to the physician owned hospitals. And then they turn around and take the sicker patients or the patients who maybe don't pay as well to the non-physician owned hospitals. And largely that's been debunked as well. There still continues to be some information coming out of the American Hospital Association and the FHA saying that that still exists, but I think most of the data does not support that. So, at this point, sitting here 2024, we're at the last year of this particular session, and starting in January, there'll be a new session of Congress. We are still fighting for a change. However, I think at the end of the day, it's going to be difficult to move this year, although we are starting to see traction around really two ideas. One, allowing for new facilities that are more than 30 miles from a current existing facility. So if there's an area that's underserved, that is rural in nature, that is far from a major hospital, there would be the opportunity for physicians to own in that type of a facility. The second would be the expansion of current physician-owned hospitals. A great example in our backyard is Doctors Hospital. Doctors Hospital Renaissance is the large tertiary facility, or one of the large tertiary facilities in the valley, in the Guadalupe Valley, the Rio Grande Valley. And when you look at the services they provide, they are across the spectrum, and they have a high Medicaid population. And during COVID, they actually were one of the major facilities treating patients in the state of Texas, and were out of beds, as many hospitals were, and needed to expand to provide additional access for COVID patients in the Rio Grande Valley. And unfortunately, because of these laws, we're unable to do so. And that really creates a public health emergency issue. And so now there's some definite discussions and potential agreements to allow us to expand physician-owned hospitals. We have more momentum than we've ever had. We have had a markup in a committee. So these conversations are definitely progressing. I will say the major headwinds are coming from the large healthcare organizations, mostly the hospital systems, who don't want to see physician-owned hospitals exist. And the second group that is largely fighting us is honestly Democrats, because this represents a potential major political loss to have any component of the Affordable Care Act repealed. You may recall right before Senator John McCain died, he cast the one vote to protect the Affordable Care Act from being removed or eliminated. And as such, as you can imagine, there is a strong desire to ensure that the entire Affordable Care Act is maintained and preserved. It was a landmark legislation when President Obama was in office. And so it is very difficult, even though it makes a lot of sense, it can be very difficult from an emotional standpoint to allow for a change like this to occur.
Yeah, that's great context, and obviously you're well versed on this topic. But if you were, speaking to the audience related to physician-owned hospitals, what would you say are the advantages of physician-owned hospitals versus your non-physician-owned hospitals? Or is there any advantage, or are they just, sort of similar in course? What would you say to that?
Yeah, I think a couple of things come to mind. Probably the biggest thing that we hear as far as why are people excited about it has to do with something that we term consolidation, right? We're
Hmm.
seeing physician groups purchased, we're seeing hospital groups purchased, we're seeing groups combine, we're seeing, even in our community here in San Antonio, we just recently had an independent private facility in the Hill Country purchased by HCA.
That's right.
So what we're seeing is consolidation in the market. And what if you look at it from the insurance company's perspective, their ability to contract significantly goes down when the number of choices they have in a market goes down. And so the presence of Allegiant, whether it's physician owned or not physician owned, but the presence of these smaller facilities, these specialty hospitals to provide um, care, provides alternatives when negotiations are very difficult with large healthcare entities. And the Blue Cross Blue Shields or the Uniteds of the world would rather find an alternative for the large employers in the community. So that's one thing. I think beyond that, if you look at the quality metrics, physician-owned hospitals consistently perform at or better than their colleagues that are non-physician-owned. And I think that makes sense. When physicians are bought in and they're a part of the day-to-day and they're a part of the decision-making process that's being had, clearly they're going to want to ensure that the best care is being provided. They're more invested in the care that's being provided at the facility level. There's less bureaucratic stops to getting the things that they need or the care that they need to provide. And so it's critical that there's a partnership there. And I think we're seeing more and more of an employer employee relationship in the large healthcare systems. And physician owned hospitals provide that alternative where we don't have an employer employee relationship, but instead a collaborative relationship where the owners of the hospital are also the very people providing the care. And again, that leads to efficiencies and improvements in outcomes.
Yeah, I think that's a great point. And that's obviously one of the advantages of Legent Health and what we provide to our communities, to our physicians. Because having that partnership with the physicians, whether it be the procurement of equipment, the outcomes related to the care that we provide to our patients, having that collaboration and partnership is a very clear distinction in my mind, going to a physician-owned hospital versus the latter, non-physician-owned hospitals, just because of the high touch point that we provide. And obviously you're a great example of that in our facility in San Antonio. So I think that's a really good point. So this is a critical topic, and I'd like to stay close to you on this one, Dr. Bruggeman. I know you've got a podcast as well. Maybe shout that out to the public, because this and also the topic we're going to get into with prior authorization, along with another myriad of topics of things that you covered. How can others reach you on this specific, not this specific topic, but related to other topics with your podcast?
Yeah, so I chair the Council on Advocacy for the American Academy of Orthopedic Surgeons, and I think even the orthopedic surgeons listening in probably don't even know what that means. Our
Yeah.
our uh, our governance of our organization is broken up into multiple councils. There are four main councils that advise the board of directors. Um, I chair one of those four main councils, that being the Advocacy Council. And what does that entail? We have the Coding, Coverage, and Reimbursement Committee that reports to me. The Medical Liability, so medical malpractice group reports to me. We have the Political Action Committee, which is the group that gives money
Mm-hmm.
to to our members of Congress in support of musculoskeletal needs. And the final group is my advocacy council itself, which oversees regulatory issues that might be FDA, HHS, CMS, so all of our main regulatory agencies in Washington, D.C., but also does a lot of lobbying on behalf of patients and on behalf of surgeons who treat patients with musculoskeletal issues.
Excellent. Very good. So I think that segues really well into the next topic that we're going to jump into, and that has to do with the impacts related to prior authorization. And I've listened to some of your podcasts and some of your posts on LinkedIn where you've addressed this and you keep us up to date. But give us some background on this topic and maybe some talking points related to this critical topic, prior authorization.
Yeah, so prior authorization obviously is, frankly, a way for insurance companies to improve their bottom line, right? At the end of the
Yeah.
day, it's couched as a way of ensuring that appropriate care is provided, but I think we all know that that's really not what's happening.
Yeah.
If you look at San Antonio Orthopedic Group, which is in my community, they did a great look back on how much money they have spent trying to get things authorized. And they roughly spend
Hmm.
about $500,000 a year just on prior authorization. And that's in staffing specifically. Their success rate at getting prior authorization is 99%. So you could almost call this a tax, right?
Yeah.
If you want to do surgery on patients, you're going to pay $500,000 a year if you have 30 orthopedic surgeons in order to get the surgeries done that your surgeons, who are medical doctors, trained, board certified, know their topics, know their patients, know what their patients need. You have to pay $500,000 a year in order to do those surgeries. And that's essentially a tax. And the goal of this is to discourage patients and discourage physicians from pursuing appropriate care. I will say, obviously, the opposite of that is that there are procedures that are maybe recommended by doctors that may not meet the criteria or the typically approved reasons for doing procedures. And there has to, in all things, be a check and balance. And I think everybody understands that. But prior authorization has gotten to a point where it is extremely intrusive, very expensive. It's delaying patient care, which is leading to worse patient outcomes. And it's putting physicians out of business. It's putting hospitals out of business. We see daily headlines about groups that cannot provide care, and that just can't be in the best interests of the general public.
Yeah, I got to tell you, within our organization as well, in just my short time here over the past year, we've had to put in so many layers of team members and processes and systems to address this matter. And to your point, the success rate is high, but it really shows that is that really a requirement that's needed in order for us to move forward. I understand the checks and balances that is needed because of the abuse of, certain physicians, over time. But to your point, it is definitely an administrative burden that's been added on to many organizations, and frankly, some can overcome it, but many, as you can imagine, that don't have the financial fortitude to be able to withstand it, are facing some significant challenges. So what's the answer here? Like, how is this being addressed at a higher level to try to mitigate this and find a much better balance of appropriateness?
Yeah, I mean, I would tell you there's a lot of things going on. So Texas is fortunate at our state level. We were able to successful lobby for gold card legislation.
Hmm.
What does that mean? Um, Gold card is the term that's been given, but essentially, it's a pre-approval for your procedures. It's approved by type of procedure and by insurance company. So you might be approved for physical therapy if you're, for instance, a physical therapist or you owned a physical therapy practice, or by MRI if you owned an imaging facility. Or for us as surgeons, you might be approved for musculoskeletal surgeries. Um, the insurance companies go back and select a handful of prior authorization requests. Those requests are then reviewed to see whether or not you were successful on those requests. And provided that over the sample that was taken over a 6-month window, you were successful at least 90% of the time, you are given a gold card for the next 6 months, where you do not have to get prior authorization for anything that fits under the areas that you got a gold card for with the insurance carriers that you were approved under. Every 6 months, there's a look back period for them to say, well, when we weren't asking you for prior authorization, did you do a good job? Were you still holding to the standards you were held to when you had to go through prior authorization?
Hmm.
And the answer, if you did a good job, then you get the gold card for the next 6 months again. And that just keeps going and going and going. So every 6 months, you are reevaluated. It's not being perfectly implemented, but it's certainly a great start. West Virginia has done a similar law, and there are many, many other states that we're helping to try and implement similar laws. But kind of a notice to the audience, when we pass a state law, state laws only apply to what we call non-ERISA plans. Those are
That's
plans
right.
that are administered by your state. So that might be state employees. It might also be Obamacare plans. Those are typically administered by the states.
Hmm.
It does not include the insurance that's provided by people who typically get it from their employer. That requires a federal solution. And so we have taken the Gold Card Act and put it at the federal level. Congressman Burgess from the Dallas area is the one who is the author of that bill. We have also been working on trying to streamline the process, reducing the amount of time from when you submit to when they have to respond, both for regular cases as well as urgent cases. And recently, even though we weren't able to pass the legislation last year, even though we had broad bipartisan support to pass the legislation to improve the speed at which we get prior authorizations done and to require electronic submissions. Even though we weren't able to pass it, the executive branch under the White House with CMS actually proposed rules that mimicked the bill we were trying to pass. And so those just went into approval. They're not going to go into effect for a few more years to give everybody some time to adjust and change to the new regulations. And then we're going to continue to try and pass more legislation to try and reduce the amount of prior authorization burden. And again, we have very broad bipartisan support against the insurance carriers on this.
All right. So looking through your crystal ball, what does the next 2 to 4 years look like relative to physician-owned hospitals, prior authorization, and other sort of critical matters that are impacting the physician and healthcare community?
Yeah, so there's a lot of things coming down the pipeline. There's the potential for a CPT code for prior authorization that's been floated now, where physicians would be paid for the amount of time and effort they're putting into prior authorization. It's
That's
unclear
interesting.
how that would be done, but it's not, it's conceptually a good idea. I just would remind everybody that once we're being paid for performing this work, it somewhat gives a green light to increase the amount of prior authorization. So it's
Yeah.
always be careful what you wish for.
Yeah.
There's also been some recent arguments made that we need to go back to the Hill and talk about star clause. Star clause largely prevent physicians from owning in various entities. But the comment that's being made is, well, if there's already prior authorization and there's already somebody else who's looking over the shoulder of the doctor, ensuring that things are being done appropriately, why do we need star clause? Or maybe we need to significantly peel them back and provide more opportunities for physicians to own. And I think, again, all this boils back to the concerns about consolidation, the concerns that companies like Legent are very difficult to start, very difficult to get off the ground. It's been very successful. However, it didn't come easily. And
Right.
not everybody has the ability or the money or the wherewithal to do that. And keeping physicians private, keeping insurance companies at a reasonable scale so that there's competition is really, really critical ultimately to providing the best possible care. And I think that is going to be a continued theme. As it relates to physician-owned hospitals, I think the themes are the same. We need to encourage competition. We need to give physicians opportunities to earn money in ancillaries. I talk about physician reimbursement going down every year. We went down 3.36% this year. How are physicians making up for that income? Largely by either dropping out of health insurance carriers and going out of network, or they are trying to increase the number of ancillaries that they own, meaning hospitals, surgery centers, skilled nursing facilities, physical therapy units, because those things are increasing with inflation. This year, hospitals got a payment increase. This year, surgery centers got a payment increase. This year, skilled nursing facilities got a payment increase. Home health got a payment increase. Physicians got a payment decrease. So, physicians are recognizing that the pay that they get paid to do the work they do is being less and less valued by insurance carriers and less connected to the actual value they provide. And so they're trying to be able to own in these other ancillaries that they manage in an effort to capture more of the care that they're providing and ensure that they can keep their doors open. And I think that's critical and important to the future of our healthcare system.
Yeah, I couldn't agree more, obviously. Really good points. And look, I want to personally thank you for being an advocate for Legent Health, obviously, as our chief medical officer. But I think the audience and myself included want to thank you for just being an advocate for healthcare in general and really speaking for the physicians who are taking the short end of the stick in this entire process. As you mentioned, all these other organizations were able to get a lift, and the physicians are getting cut, and that's not a sustainable trend if we want to continue to have physicians remain independent and to provide the high level of care that we know that they want to provide. So really want to thank you for that. And look, you're in depth in a lot of these topics. If folks wanted to hear from you on a recurring basis, how can they reach you? What's the best medium for them to be able to get updates from you from an advocacy perspective?
Yeah, so we, if you're an orthopedic surgeon, you're a member of the American Academy of Orthopedic Surgeons, we send out a notice, and Advocacy now. It comes out, I think, every other week at this point, that just highlights the changes. We're constantly updating our membership and letting people know what's going on. You can certainly subscribe to our podcast, which is the Bone Beat podcast from AAOS. You can get it on wherever you listen to podcasts. And then I'm more than happy to meet, talk, or reach out. And I'm happy to be available. Our academy staff in the Office of Government Relations in Washington, D.C. is always available. We are here to ensure that we continue to protect the practice of medicine and that there is a future for hospitals like Legent, surgery centers, and independent physician practice.
Fantastic. All right. Well, good. That's going to wrap us up, everyone. Again, thank you, Dr. Bruggeman, for making time out of your busy schedule. I know you're traveling, you're practicing medicine, you're on many boards, et cetera. So thanks for making time for this podcast. Look forward to re-engaging with you guys over the next few weeks. Take care, everybody.
Thank you.
Thank you for listening to Beyond Bones and Muscles, a Legent Health podcast. We want to hear from you. Subscribe and leave us a rating. Your feedback helps improve our show. For more information about Legent Health, go to legenthealthservices.com.